My name is Megan Claire Craig-Kuhn. I work at the Minnesota Department of Health Oral Health Program. I'm a project coordinator that's just wrapped up the older adult BSS. But we finished data collection about a month ago, so the results of that are still quite a few months out, but we're very happy to be done with that. And Bilkis Khan, our evaluator and epidemiologist. More of you will know Bilkis than myself. So today, this actually is a very apt graphic for the day because some people may look at this and see a person with a broken umbrella. And some of us may be battling that on our way to the cars today. We should be pretty fast, so hopefully we can get everybody on the road safely today. But really, this is our person at work. So today we want to talk about what work we have been doing, what strategies inform that work, and kind of what we're doing now and where we hope to go. Let's see if I can. So we're improving oral health through innovation, integration, and implementation. So we want to talk about what are opportunities moving forward in the near future. Objectives for today, talk about those strategies being used to implement innovative models of integration and collaboration. So that's innovative workforce models and integration of primary care and dentistry or oral health. Align our direction with federal priorities. Review current work, and then explore what projects we'll be coming into. We're coming into a few really big ones right now, and so we'll discuss that and ways to get involved. The commissioner wrote a foreword to the state oral health plan, which came out in 2013, that image. Most of you are probably familiar with that, but we really like the letter that he wrote because he touched on some of the really big topics. And quote from him, the most effective solutions are school-based dental sealant programs, fluoridated water, increasing access to affordable care through innovative workforce models. And then he also goes on to discuss healthcare homes. And so these are all things that are still important to us. I'm sure will appear in the next version of the state oral health plan, and then also align with federal priorities. So a couple big ones. That first one mentioned is the CDC's Vital Signs that just came out 2 months ago. Did most people catch that on dental sealants? 2 months ago, October, yeah. Mm-hmm. And if you didn't catch that, please look for it. It was quite good. I hope a bunch of you caught Dr. Rose's talk just before this one, talking about that collaboration between public health, primary care, oral health, joining all of those together. Workforce innovation is very important to federal and something we're doing as well. And then the Healthy People 2020 goals, and there are so many. we didn't want to list them, but those I'm sure we're all familiar with go into across the lifespan, preventive, access to care, all very important to us, and luckily at the federal level as well. So Bilkis.
Okay, thank you. Yes. So I'll take the stage. How many were in Dr. Rose's presentation? How many of you attended? Okay, that's great. The reason is a lot of material which you see you will see that it aligns with what he was talking about. So that's good that there is some frame of reference. We keep on going. As Megan talked about, that MDH, whatever MDH does, we try to align with the federal priorities. And the federal priorities talked about, which she showed a slide before, is preventive care, access to care, medical and dental integration. So this particular work shows that our priorities, which are listed in Minnesota Oral Health Plan, and I'm sure some of you were involved when this plan was being developed. So the main goals of these plans and what Megan shared with you, Dr. Ellinger, who is the Commissioner of Health, MDH Commissioner of Health, he talked about is exactly aligned with what it has, what Dr. Ellinger said in his foreword, and what the priorities of the nation are. So based on that, this is what oral health program does, is that we are trying to integrate oral health with primary care. And we'll talk about in detail that we have recently got the funding from CDC and HRSA to go with those models of innovation. And then we also very closely work with a lot of partners to ensure that, that healthcare providers who are practicing in advanced roles, that their programs are being implemented and they are being utilized in addressing the access to care issues, ensuring stability of the workforce also and training of workforce also. And then, of course, we know that there are 2 evidence-based oral health strategies, which all of us know. One is a community water fluoridation, and the other one is school-based dental sealant program. So those are the 2 major evidence-based dental initiatives are there, and MDH is very, very closely working on those too. And then, of course, if you want to work on all these things which we are talking about, you need to have partners, you need to have collaboration. You cannot work in silos. We all know that silos don't work. That's why we all the time talk about that. Let's break the silos and work together. So that's what goes in. And then when we talk about all this, what we are doing, how are we going to know whether what we intended, we achieved that? Unless we have some kind of information, some kind of a data, which tells us that, yes, we are moving in the right direction, and this is what the evidence shows us. So surveillance and evaluation is a core, I would say, principle or a core value for us, that we do evaluation and surveillance. And for surveillance, in one of my past presentations, I talked about that oral health program has established a Minnesota oral health statistics system. This is an online statistics system where you can find data related to oral health, and that was being funded by Delta Dental of Minnesota Foundation, so I would like to recognize that also. It's how many of you have ever visited that site for any kind of oral? Not too many people. Please go and do. You will enjoy it. That, some kind of a data. You can play with data also. It's just like, if you love it, you really will like it, okay? And it's very, and the way even the text is being written, the data being explained in a very easy way to understand. Sometimes some of us, when we look at the data, we're like, oh, no, don't get there because this is data. But when you read it, we have ensured that, health literacy level, we talk about that, you have to create materials which people are able to understand. So those kind of all concepts are integrated into that surveillance system. So you would really enjoy it. So I want to be careful to push any of the buttons because we saw some experience in the other room. So I don't want to lose your people. So I think this should work. Oh yeah, okay, good. Because I don't want to mess up here. So when we talk about the strategies or the priorities on which we work, we try to follow this approach: policy, system, and environmental changes and approaches. And I think those people who are long enough in the system, you probably see that this is becoming a little kind of in fashion in public health, that bring changes to policies, systems, and environment, and they go hand in hand. You cannot do things in isolation again. Like when you change policies, they trickle into system. And then you have to do something in environment to make things happen in the system also. But this process is not a linear. It doesn't mean that you have to change a policy so the system is going to change and the environment is going to change. Maybe you bring something in the environment which influences the system and then it becomes a policy. Or you do something in the system where it gets into the policy and the policy impacts environment. So that's important that we work in all these 3 areas, that how we can influence the policy, system, and environment. And when we work this way, it's more long-lasting. It's more permanent, more sustainable as compared to we say, okay, we just have to work on the policy, we just will work on the systems, or we would just only work on the environment. So we have to keep in mind that we have to work in all 3 areas to influence each other. Remember, it's not a linear process always. So you can work on policy, which can influence the system, or you are working on the environment, which will influence the policy or the system. So either way you can go. But this is very important that we keep in mind, and in Minnesota Department of Health, we ensure that we follow all these approaches to make sure that our policies, our strategies are working. How many of you are familiar with these two? Very good. Okay. There is a difference between on left-hand side. I want to make sure that this is on the left hand. On the left-hand side is an Institute of Health Improvement triple aim, which is more related to the system improvement, like healthcare system improvement. That's why we see more cost-related stuff. Population health definitely is there, and then experience of the care itself. So this is a model which is more into improving the system itself. Then it comes, and we talk about a lot of disparity. When we talk about in public health, we are like, oh, Minnesota is doing very well as compared to the rest of the country. But when we go to the population level, there are segments of population which are not doing very well. So we talk about equity. So that this model is a health, we call it a triple aim of health equity model. And this came out when MDH was working on health equity, because addressing health equities. Recently, 2 years ago, 1.5 years ago, a report also came on how to address health equity, and all the priorities are set in there for MDH, that how they are going to work. So if you see really this model, this is a very interesting model. I really love this model. This is, this one is sitting on my desk in a color so that I see all the time, because if in reality if you see, what do you need? If you want that the population is healthy and they are given, people who need the most are given the priority and given their needs, what do you need? You have to have an understanding of health. What creates health? Is just coming to the clinic or going to the dentist creates health, or is beyond that? So first we have to understand what is out there which creates health. So when we talk about creating health, expanding understanding of health, we need to know that health is impacted by environment, impacted by culture, impacted by other things, or the area where we live. So the education we have, so it impacts. So implementing health in all policies is very, very important. Unless education departments have some policies which can influence health, like schools, for example. Schools should have healthy beverages available, or water available, or less sweetened sugar sweetened beverages available, or safeguards for mouth guards, for example, if the students are playing on ground. So those kind of things are related to oral health. So that is one. And then of course, where people live. Can they have access to their clinics? Can they easily go to the clinic? Do they have bus routes available to go to the clinic, or are they going to ride with somebody? So then it becomes very important, and which kind of housing they live in. So implement health in all policies means we have to ensure, if you want to create health, that all the other sectors beyond health should also include health in their policies. And then strengthening community capacity. Nobody can create a health unless community itself stands up and says, yes, I want to do it. So this is what, if we want to really aim to address equity issues and disparity, we want to address that, we have to ensure these three things are happening. Okay? So that's what MDH is trying to do, is that keeping all, remember, I'm not talking about random things here. They all connect with what our priorities are. And these priorities are not only MDH priorities. These priorities are the nation's priority. So that's what we have to remember. Okay. I thought that I'll give you a little bit of a history. I really like it because I try to read it, that from where we were as oral health people. Okay, 5.5 years ago, I joined oral health program. Before that, I never had a clue of oral health, except that I had a bad toothache and I had a very bad experience with tooth. Okay, and maybe some of you have the same experience like mine. So I started digging out that why people don't understand that mouth is a part of the body. So then I realized that it's not a long time ago people started realizing. It's only when 2000 Surgeon General's report came out, at that time people like, yeah, mouth is really part of body. Otherwise, unless I have a toothache or I have something else going on, I never care about mouth. I don't even think that I speak because of my teeth. General people don't even think. When you tell them, they're like, really? I'm like, why don't then babies talk, or the older people talk without teeth? That's the reason. They can't talk very well because of. So having said that, a lot of people did not have a clue what oral health is and how it relates until in 2000, Surgeon General's report came out, and people started opening up. And then after Surgeon General's report in 2003, if you are aware of these documents, these are very interesting documents. If you have not read, and if you are in oral health, I'm telling you, for God's sake, please read these documents. If you don't know what's going on, then it means we are working again the same way, that, oh, I'm an evaluator, I'm going to just evaluate. Rest of the thing, I don't care. Don't behave that way, because that's very important. We understand from where the oral health whole this culture is coming and where we are leading. If we have a better understanding, we'll be able to do a much better job than what we are doing. I'm not saying that you are not doing a good job, okay? Everybody is doing a good job. So in 2003, then came another one from the Office of Surgeon General, which called a national call for action to promote oral health. And in this one, they talked about something very important. And I could not memorize it. I love to memorize, but there is too much to memorize. So in this particular report, they talked about 5 action items. They said, change perceptions of oral health was first. It means there was a problem with perception. That's why the first action was change the perception about oral health. The second was overcome barriers by replicating effective programs and proven efforts. Which are those? School-based sealant program and community water fluoridation. Okay? The third one was build the science base and accelerate science transfer. And the science told us over so many years that community water fluoridation makes a difference. And then also, science told us that school-based sealant programs are effective. So that was the third action they said that we have to go with. And then number 4, increase oral health workforce diversity. We need to have diversity because our population, our demography in the US is changing. So based on that, we have to bring a workforce which can, like CHWs, those people who attended this morning CHW's session, they probably recognize that how important those workforce is. Then the 5th one was increase collaboration. And I can not talk enough about collaboration, we know that. In 2003, that came as a call for action. So these are the actions we need as an oral health community. Then came in 2010, when HHS, which is Health and Human Services Oral Health Initiative, that's called 2010, and they also highlighted 9 new initiatives. And if I take more time, I can tell you which ones are those, and you will say, oh yeah, we are doing these. The reason is because they came from federal agencies. So that's why we are doing it, or we started doing it. One of them was that Head Start Dental Home Initiative, National Oral Health Surveillance Plan came out, Innovative State Medicaid Dental Program came out, the reviews, National Study on Oral Health Initiative. Then came the Early Childhood Caries Initiative, Clinical and Translational Science Program, a cultural competency e-learning education came out of HHS report. Before I get into the other ones, I want to tell you about 2010 was the time when, right now we are talking about Healthy People 2020. In 2010, we probably talked about Healthy People 2010, isn't it? At that time, remember, at that time, oral health was not a leading health indicator. Right now we know that in 2020, we have one indicator as a leading health indicator. And oral health as a leading health indicator was not there before in 2010, when the 2010 came. So at that time when they were deciding that what should be the indicators, leading health indicators and others for the next decade in 2010, at that time they included oral health. So which means that probably report of 2000 was kind of a catalyst for that thing, that they started realizing that, you know what, oral health is important. It should be a leading health indicator. The reason, if an indicator becomes a leading health indicator, then federal agencies pay more attention to that area. So oral health was not being got any attention from anybody. So that was the time. So I'm sorry, I forgot that, and later on, sometimes it dawns on you, and you're like, oh my God, this was happening too. So that's why it doesn't appear there. So it just occurred to me. Anyways, so after that we see, and then something else was going on. How many people remember Minnesota healthcare reform? When did that come? When the healthcare homes came in. Minnesotans, wake up. 2008. It was 2008 when the healthcare homes came out from nowhere, probably, I would say, for our state. Okay? So that was 2008. So there was so much going on out there. which I think we need to know that where we are today, why we are today, so that because today we'll decide where we will go tomorrow. So that's what happened. And then in 2011, Institute of Medicine talked about improving access for oral health for vulnerable and underserved population. And this is the thickest document, if somebody has seen it, 289 pages or something. I should have the 296 pages. It's a huge document, but I think it's such a document. If you read that, even some of the pages, you would feel like that you are the guru of that oral health. I know what's going on in oral health. I know how can I fix it. So that's a really, really important document. If you have not seen it, please, I would beg you that at least see it. Go online and just see it. It's available online too. Okay. And then in 2014, HRSA, which is probably most of you know that Health Resources and Services Administration got this document out, Integration of Oral Health and Primary Care Practice. Are you familiar with this document? Okay. This document came to do what? To create a clinical competency in the primary care settings to the primary care service delivery professionals so that they can deliver oral health. So that's another very important program came out, like this report came out. And then there were some pilot states also were working on that. And as far as my memory goes, there was one program in somewhere, I don't know whether that is considered as a North Dakota one or Minnesota one in Moorhead area, which was working on this one. And their evaluation, when HRSA brought their evaluation report, that mentions there that one of the FQHCs around that area, Moorhead area in Minnesota and North Dakota, that was part of this HRSA program. So I don't know whether they considered it as Minnesota or they considered it as North Dakota. And then this one is a paper which Dr. Ross was talking about. This is a white paper. Please read this. If you are interested in integration, read this one, primary care integration. So that just came, it's a new paper. And then in 2015 it came, and Qualis is the one who basically published this paper. And then in 2016, just now, a month ago or 2 months ago, they published another one which is related to how to implement it. I just made a copy for myself like this, so it's easier, okay? So these are the documents which I would suggest that if you are interested in integration and finding out that where we were as an oral health and where we are today and where these federal agencies are going, because we cannot go on our way. We have to go with the nation. So if you want to know where the nation is going, what the people who are sitting in those positions who decide for the nation, at least read a little bit of this. If you can't read it, this is too much to read, but please, those people who have read, I salute them if they have read all of them. Okay, so now having said that, all this story, why I talked about all these stories, okay? So you must be wondering why am I talking about all these stories which don't connect to us. But anyways, so MDH just recently got 2 major fundings from one from CDC and the other one from HRSA. And these are competitive, so they are difficult to get. Every state applies, so we feel proud of ourselves that we got those 2. And both of them, interestingly, started at the same time, and they will finish at the same time. So there probably would be a lot of work for us to do. But anyways, these are one that we have to really work hard to get these 2 years over, and then as soon as these 2 years are over, so to reapply is another work, okay? So that way we will have a lot of work to do. So Megan Claire and what I will do is that we will try to give you a little bit of a flavor of these 2, so that, because it relates to all of you. All of us, actually. Don't feel that, oh, this is MDH work, forget about them, let them do whatever they are doing. It's everybody's work. So that's why we thought that we share that where we as an MDH is going based on where the nation is going and how you all or we all can participate together, okay? So I'll talk about HRSA grant, and Megan Claire will talk about the CDC models of collaboration. And I think you will talk about it was competitive and everything, that only 6 questions, okay, great. Okay, so the common thread between both of them, okay? The common thread between both of them is medical dental integration. So if you see that both of grants, although slightly the population with whom we will be working and a little bit of strategies would be different, but a common thread is what Dr. Rose was talking about also. Okay, the workforce innovation, which is a HRSA grant, we call it 4 eyes. I have 4 eyes, 2 of these and 2 of these, okay? So 4 eyes. So these 4 eyes are, one is innovate, like try to be innovative. So we feel like that medical dental integration is an innovation, kind of. For our state, we are still in infancy in doing integration. There are other states who have done much more than we have done so far, dental medical. And then we thought that this innovation is bringing us to integration, and then we will be implementing that integration, and then hopefully we'll make some impact. So we call it 4 eyes. Okay, what is this all about? There are 3 main focus areas we are working. One is integrating oral health primary care, as I said, with medical, and all of them are for underserved population. So we have to ensure on our end that those are the population which we are serving, our underserved population. So when we are writing this grant, we ensure that what we are writing about or which programs we will be working with on these grants are coming from underserved populations. And then the second one is health providers practicing an advanced role specifically designed to improve oral health access. And Laura, we have Laura from MDH. Can you wave your hand, Laura? From Workforce, she's from Office of Rural Health and Primary Care, and she does a lot of data analysis on workforce-related things. And she's one of those also who worked on the evaluation, dental therapy evaluation, which legislature mandated MDH to submit to them. Laura was part of it. And the third is community-based prevention services, and I'll talk about it in a little bit detail later. Okay, when we talk about integration, I thought this is very important that we understand that there are certain building blocks. You need to have that. If you don't have those building blocks, it's very hard that we can achieve any success. So based on that, of course, why do we want to integrate? So that it's more access to underserved population. That's the main goal, okay? For that, if you want to do in collaboration between two like medical and dental, you have to have a collaborative team. You cannot work that way. You can say, okay, you know what, this is a dental community I have gotten, this dental office, and this is the other one is my medical clinic, and we will be working together. We have to have a coordinated team, collaborative team, that okay, 2 people or 3 people from here or 3 people from here. So we have to have that kind of a team. And then care planning and coordination. Because you know, when we say a referral is going to be made, whether it's from a dental office to a medical side or from a medical side to a dental side, we need to have a care planning. We cannot just work without planning. And then we need to have that to be coordinated to ensure you cannot just say, okay, you go to the dental office, and then not figuring out whether that person went to the dental office and got the treatment which was needed or not. Or if a dental office sends a patient to a medical center, the dental office had to ensure that this person went there, got the treatment, and this is the treatment which was required. So coordination means you have to coordinate that, otherwise it doesn't happen automatically. And that's why a lot of things fail, because we said, okay, you know what, we shook hand and sent this person to his or her way. We have to make sure that the person got there and got the service which needed. So that's another building block, very important building block. And then for integration, you know, and IHI, triple aim, I showed you the triple aim, that little triangle, that has the basic concept there is a patient-centered care. And healthcare homes, all the healthcare homes which are working in Minnesota, they go with the patient-centered. Patient is the main. So you have to include the patient in there. So if you want to make sure that otherwise if the patient, there is no buy-in from a patient to get the dental or oral care, then it means that probably you may not be successful. So that's why patient-centered, it has to be patient actively should be engaged in that process. And definitely we need community sources there, a lot of community workers and people in community who can help us, and community partnerships. Communication is the key. It has to have communication. We know that communication, in anything, we need communication. So communication is another one. And then we have to have performance and reporting and quality improvement systems in place. But how are we going to know that whether we achieved what we wanted to achieve? So therefore, we have to have some kind of a performance reporting. Whether in the referral, the patient was satisfied or not, or even the staff is satisfied or not. Maybe dental hygienist who is sitting in a dental clinic and trying to integrate with the other medical clinic, she's not satisfied or he's not satisfied. And on the other hand, nurse practitioner is upset with a dental hygienist. So that's very important that we do kind of a performance reporting and quality measures, that are we doing the right thing? So that's very important, that it should be integral of it. And then of course, when we talk about referral, bi-directional referral, we need to have a participant registry or some kind of a tracking. How would I know? So as a dentist, if I'm referring a patient, I need to know what happened with that patient, so that next time when the patient comes, I know what to do with the patient next time, and the same happens there. So in that way, some kind of if there is a registry, go for it. If not, then at least some kind of a tracking mechanism. So that's very important, that building blocks for success. Okay, what we are doing right now. We, MDH, I want to remind you again, when this state plan, when we published this state plan in 2013, probably a lot of people would remember that, and a lot of people got in their mail. At that time, we also had a summit. How many people remember that summit, which talked about coming together, integrate oral health, and so that's where we came from, and we always thought about that, how we can integrate ourselves into healthcare home. So this time now we have got some funding, so we'll be piloting an approach of dental medical care in a Stern County. And we have got a lot of information. When we were writing at that time, we did some data work and some analysis that what would be the right place, and that's where we found out that Stern County is a DHIPSA, dental HIPSA also. It's a partial dental HIPSA. And then there were some local reports available through which we got some data. And we are not working with everybody there. It's too hard. It's not a very small county. So in that way, our emphasis is high-risk immigrant population from East Africa with diabetes for this particular project, which Megan Claire will talk about. It's not diabetes, it's different chronic disease, okay? So we will be working with East African population with diabetes. And then again, team approach, we will be going with the team approach. And in team approach, we need to have a primary care and dental officers talking to each other. And then it's a bi-directional referral we are talking about. And something else, how many people are aware of PPOD? Have you heard of PPOD? No? Toolkit? National Diabetes Program? No? No? Oh, okay. So now I know more. I can say anything now. If people don't know, I can say anything about it. Okay, so this toolkit was developed by National Diabetes Education Program by CDC and Institute of Health. And this is called Pharmacy, Podiatry, Optometry, and Dentistry Toolkit. And that was developed for patients with diabetes. We know that when a patient has, a diabetic patient can have problems with these three things, okay, health problems. And then because of medication, there is a lot going on. So this tool was created so that those people who are dealing with a diabetic patient, so they can understand that what kind of a messages the diabetic patient needs. So that's what we will be implementing, the toolkit, okay? So that's one thing here. Now we'll go to the second area. One is a healthcare home, which we will be working through HRSA project. There's another one, which is where Laura is the one who will be helping us with collaborative practice role. That's because it's strengthening. When you strengthen the workforce, you have more stable workforce, access to care issues can be addressed. That's another puzzle piece for us. So here in this particular one, what Laura and her team is going to do is that environmental scan, review that what's going on in terms of a dental hygienist, collaborative dental hygienist, and they are working very closely with Normandale Community College. Are people aware of that they got a 5-year funding from HRSA also? And it's a big initiative they are taking, and I'm very proud. I'm working with them also, so I'm very happy for that. So our team is Laura and our team is very closely working with them, because then again we have to work with other partners, because when you work with partners you achieve much more deeper results and much more impact in the population. And Laura's team is working on emerging professions, like CHW is another emerging profession, how we can integrate CHWs in our work. And in fact, healthcare home, the collaboration work which we are doing with integration work with in Stern County, there also we will be involving CHWs in our program. So that's emerging profession she's working. And they are going to interview dental professionals where they would try to find out the barriers and challenges offering the services. So this is what Laura's team will be doing it. So that this is related to workforce. And then there's something slightly new we are trying to do with water fluoridation. It's not a big grant within the HRSA grant. So what we decided that we'll go to improve the infrastructure in low income and rural areas with dental HIPSAs, which are dental HIPSAs, where there is more need as compared to the regular places. So that's one, updating the infrastructure in that for community water fluoridation. And the other area which we thought that would be very important is educating the professionals, like medical and dental professionals there, about the importance of rule revision, because rule is changing. Probably a lot of people know that in community water fluoridation, the levels of fluoride will be changing. So that understanding, development of that understanding, and giving them importance of fluoride in water is what we will be talking about. For the dental sealants, what we are gearing toward right now is, how many people are aware of ESSA? Every Student Succeed Act. In Dr. Rose's presentation, we saw that how many school days are missed if kids have a dental problem, and we know that, okay? And there are other things in the school you can do it. So every student succeed, when we talk about when this is being developed, at that time we want to ensure that oral health, some of the oral health strategies which can be incorporated into the schools while this is being developed, we become part of it. So we are working very closely with MDE right now, Minnesota Department of Education, for that. And then, of course, we want to integrate oral health strategies into the school districts. That we are working closely with MDH has a school nurse, which works with all the school district nurses. So we are working very closely with that, so that these policies, the oral health strategies are incorporated into the school health. I don't want to digress here, but right now it's interesting just to mention that the Minnetonka School District, we are working with them also. Their program called Vantage program, where the high school kids are exposed to different careers, where they go and explore about the careers. So there, two groups of students, each group comprises of 4 students, are working with us very closely to find out. One group is working on that what kind of oral health services are available within the school, and why, are there policies which hinder the oral health services within the school? And if there are, why are those? How can those be changed? So one group of students is working on that. The other group of students is working on health literacy, that oral health messages are available for people to understand easily. So that's another piece that we are trying to do, that if the students are involved and they bring stuff in, that probably becomes easier to get into the schools. And we know that, everybody knows that if only working with MDE is not going to help us a lot. The reason is we have independent school districts. Okay, so every school district has a different way of operation. So even if you go and work with MDE, which is very good because probably ESSA will come from MDE, from there, but just working with MDE is not going to solve the purpose. So that's why we got involved with Minnetonka School District, because we got that opportunity to get in. And we will be doing a survey in all the schools to find out that what kind of a school-based sealant program is being offered. And then we are also developing a scalable program, school-based sealant program in high-risk schools. And of course, we are very closely engaged with Collaboration Practice Hygiene Advisory Group, which is run by our friends at Normandale, Dr. Colleen Breckel and her group. Okay, so much information, so much we will be doing over the 2 years, okay? Now we need to get a medal. we want to tell the world that, the great work we are doing. So what we have done is that we are going to have we haven't done yet the contract with them. So that's why I'm saying that we will have a contract with Public Health Law Center for dissemination of information. So they will be producing some issue briefs for us so that we can share our good work to people. And then I think I'm done here. And then we'll talk about the questions at the end. How about that? Should we keep it that way? So that Megan Claire finishes and then we go to the questions. Thank you. Yeah.
So for the CDC grant, it's Models of Collaboration for State Chronic Disease and Oral Health Programs. And as Bilkis mentioned, it was a competitive grant through the CDC. We're very happy to have gotten it. We're very proud of that. We worked very hard on that proposal. And only 6 states got it. Alaska, Michigan, one of the Carolinas. So you could have a choice between collaborating with another chronic disease unit at your own state Department of Health. You could focus on cardiovascular, tobacco prevention, diabetes, nutrition. What was the fourth one? Obesity. So you could write a proposal to work with any of those other groups within your own state health department. We chose to collaborate with the cardiovascular health unit. So this grant is kind of 2 parts. The first is that we need to do the work within our own state health department of collaborating within our own silos of chronic health. Minnesota is very lucky because our oral health unit is already housed within the Center for Health Promotion. That we work right alongside cardiovascular and diabetes and asthma and a couple other groups. So our cubes are literally right next to each other. So it was easier for us. We kind of had a leg up, which we appreciate. And the second part is then working in the community and piloting something. And so our project is to, again, with the integration of primary care and dentistry, is we're working on a closed-loop bidirectional referral system for periodontal disease and increased risk of cardiovascular events. So we're looking to have the bidirectional referral based on a periodontal questionnaire that they would do in the primary care, and then blood pressure for hypertension in the dental clinic. So we kind of have this Venn diagram of where we're operating. In the green, we have Minnesota Department of Health Oral Health Unit and the Cardiovascular Unit. In the pink, we have groups just like this. The Minnesota Oral Health Coalition and the Minnesota Cardiovascular Health Alliance will be relying on these 2 groups for their expertise. And then on the left, our community partners. There's Southside Community Health Service, which is an FQHC and a healthcare home, and Park Dental. And the benefit of working with 2 groups instead of just one is we'll learn more and be able to say more coming out on the other side. So we have an FQHC, and then we have a more traditional a clinic that uses a more traditional model. So this project happens right in the middle. A lot of moving parts. So especially in the first year, we'll be heavily relying on our advisory panel. It will include individuals from all of those groups. And we talk about moving our priorities at the federal level and our level. So this is coming from the CDC. This project and this work is a federal priority, and they're saying in your own state, in these 6 states, learn some things for us. And so we're not just staying within our own Department of Health. We're asking everyone. We're going out and seeing where we've come from. As Bilkis was explaining our history, what have we learned before? How is that going to inform this project? And then we'll hopefully have some things to share in the future. So as I said, it's 2-part. Year 1 is us really collaborating with the cardiovascular health unit, and that's kind of us walking the walk. We have this idea of dental and primary care collaborating, and we can go to clinicians and say, okay, go collaborate, have fun, let us know how it goes. But this is us within our own units doing that similar work. And if we at the health department have ties with the other chronic health units, we'll be able to participate in that collaboration as well. In year 2, we'll be piloting that project. So during the first year, the advisory panel will help us establish and utilize the plan. And then we will be asking these 2 clinics to test this out and see how the referral system works and what we can get out of it. And then the so what of, okay, MDH has gotten this funding. What does that mean for us? We need contribution from our community to know what we should be doing with this project. And we're looking to everyone to help us with that. And then Bilkis is were you going to do the last 2?
Yeah, sure. As Megan Claire said that, when we were discussing how to close the presentation, so we said that, we can joke with people that, so what? MDH got the money. What do I have to do with that? But in reality, if you really see, again, I said that, everything works in collaboration and partnership. And probably in this room, you may have already experience of working with these communities, which probably we may not know that much. Or you may have already that experience of integration between primary and dental community, and you can say, hey guys, with this kind of activities you are going, this may not work. We have something to share with. So I think that's where we learn from each other. For example, in HRSA one, which collaborative hygiene practice we are talking about, the tons of experience is sitting in this room. So how we can collaborate? How can you become kind of help for us and advise us that, what, we know that we have done this way, we can help you out with that, one thing. The second thing is that when we will be evaluating these things, if you have some kind of any experience or something, you can share with us. It could be 2-way streets. It's not necessarily we are telling you, you can come and say, okay, you know what, how can I be part of it? Like we have Sealant advisory group, we have community water fluoridation advisory groups. You can ask, Claire Larkin is our prevention coordinator, and you can send it to any of us in an email, say that how can be I part of that to contribute to that. So we will be more than happy. So that's where we would request this group. And even if who is not present here and you talk to your colleagues and they say, oh, I want to be part of this. So you are more than welcome to be part of this. And we'll try that. Whenever we get an opportunity to talk about, we'll come and share what we are learning so far. It's not that after 2 years we come and say, hey, by the way, it didn't work. Or it worked, this is the way we'll try that. If we make progress in 6 months, 9 months, 10 months, if we get an opportunity again to come back and present to any of the big group, we'll come and be happy to present and share. But our request would be, if you are doing something in the same area, you saw what areas we are working in MDH, we will be more than happy to collaborate because, we together can make a bigger difference rather than working in our own a little, we two in cubicles and you probably in offices. So that would be our request.